Hi, my name is Jade Hill. This presentation is for the Bill and Melinda Gates Foundation, and I'm presenting today on refugees and menstrual health. In 2015, a study was conducted focusing on menstrual hygiene management in women and girl refugees residing in camps in Myanmar and Lebanon. Throughout interviewing emergency response staff and refugees, the researchers discovered that there was insufficient access to safe and private facilities for menstrual health management, as well as a lack of access to basic menstrual materials such as sanitary pads. They also found that access to water to wash reusable pads or to dispose of materials was scarce. These factors can increase their risk of being exposed to violence and exploitation and make these women and girls more prone to infection without proper sanitation resources. An estimated 30 million girls and women are currently displaced due to conflict in their home countries, meaning that about 30 million girls and women are experiencing this public health problem. Proper access and resources for menstrual health is vital to promote overall wellness and increase positive health behaviors. A socio-ecological model shows the interrelations among various personal and environmental factors contributing to menstrual health. Using this model, I've identified factors that both help and hurt the menstrual health in refugees. Let's start with factors that help at an individual level. A helpful factor would be that the refugee women and girls in Lebanon and Myanmar are open to positive change in menstruation practices. A hurtful factor is that refugee women and girls lack the necessary reproductive education throughout the lifespan that empowers them to make healthcare decisions. At the interpersonal level, a helpful factor is that refugee girls report that sharing their experiences and concerns with the discovery of their period with their mothers and peers built a sense of support and trust amongst them. A hurtful factor is that refugee mothers did not feel prepared to have an accurate discussion about periods with their daughters. At the organizational level, a helpful factor is that emergency response staff providing humanitarian aid are providing access to reproductive health and menstruation education resources. A hurtful factor is that refugees do not have access to employment nor insurance coverage, allowing them to access and pay for quality reproductive and menstrual care. At the community level, a helpful factor is that the issue of reproductive health has now been identified in refugee camps, and various organizations are working to provide these resources, such as the Women's Refugee Commission. A hurtful factor is that while the media tends to highlight the various challenges refugees face, very little media attention is given regarding the menstruation and reproductive health challenges, which does not allow for an accurate depiction or the need for those specific resources. At the policy level, a helpful factor is that some aid workers and nonprofit organizations are able to provide women and girls with necessary menstruation supplies according to their preferences. And a hurtful factor is that further policy response and coordination is needed to ensure sanitary bathroom conditions for the refugee camps. I have identified 3 evidence-based interventions that would address this health issue. The first intervention includes one-to-one, face-to-face health education regarding menstrual health. This intervention will allow humanitarian and health workers to visit each family and provide this home-based health education about menstruation and hygiene practice. The second intervention involves improving the physical environment of the refugee camps by building safe and private bathrooms for refugee women and girls to use. The final intervention aims to reduce health disparities among race and ethnic minority populations through interventions that are led by community coalitions by connecting health and human service providers with ethnic and racial communities. This will be utilized by connecting various healthcare groups across the world that specialize in menstrual health and that are knowledgeable about the culture and the defined population with the refugees in need. For each intervention, we have identified specific measures and evaluation plans to determine whether the interventions are effective or not. So for intervention number 1, home-based health education, the process measure is an increase in households allowing educators to teach about menstruation and hygiene practices. To evaluate this process measure, health educators will keep track of how many households they offer their services to versus the number that actually allow them to teach. The short-term outcome measure is an increase in girls and women knowing how to use menstruation products. To evaluate this measure, the health educator will use surveys to track knowledge of how to use menstruation products at the beginning and end of implementation. A medium-term outcome measure is that girls and women refugees knowing how to access reproductive care. To evaluate this, the health educator will use surveys to track knowledge of how to access reproductive care at the beginning and end of implementation. The long-term outcome measure is an increase in women accessing that care for reproductive health and needs. To evaluate that, healthcare facilities will compare the number of patients being seen for reproductive and menstrual health care after the program has been implemented 1 year versus before implementation. For intervention number 2, the construction of private, safe bathrooms, the process measure is the turnaround time between the start of the building of bathrooms and the actual completion. We will evaluate this by comparing the anticipated and planned completion date versus the actual progress. The short-term outcome measure is an increase in refugee security and safety in using the bathroom. We will evaluate this by using a survey to collect health beliefs regarding bathroom usage and hygiene before and after program implementation. The medium-term outcome measure is an increase in accessible, safe bathrooms. We will evaluate this by comparing the number of safe, accessible bathrooms in close proximity of the camps after implementation to the number before implementation. And the long-term outcome measure for this intervention is a decrease in diarrhea cases in the refugee camps. We will evaluate this by abstracting data from the reported cases of diarrhea after 1 year of program implementation and compare it to reported cases prior to the building of private and safe bathrooms. For our third and final intervention, connecting refugees with culturally competent and specialized healthcare services, the process measure is the amount of time that passes between when a refugee requests a healthcare service and when they are seen by a provider. And we will evaluate this by tracking the date the request was initiated and when the patient was actually seen. The short-term outcome measure is an increase in accurate knowledge about menstruation. We will evaluate this by conducting a pre-implementation and post-implementation survey regarding knowledge and beliefs surrounding menstruation. The medium-term outcome measure is an increase in culturally competent healthcare delivery. And we will evaluate this by conducting a pre-implementation and post-implementation survey regarding whether the refugees' healthcare delivery incorporated their cultural practices. And the long-term outcome measure for this intervention is a decrease in death rates due to infection, and the evaluation is to compare deaths related to infection before and after program implementation. Some barriers that may arise are cultural, language, resources, volunteers, and funding. I think it's very important for the volunteers to go through some type of formal training to be culturally competent in the health issue they're discussing. I also think it might be helpful to meet with religious or spiritual leaders of the camps of that population to get any type of feedback and approval when going in to implement the health education portion, so the educators are not teaching something that will be viewed as disrespectful or against their culture. Language barriers can be addressed by the use of interpreters, and the lack of resources, volunteers, and funding would all have to be addressed through applications for grants and through thorough research of organizations that provide the type of resources necessary. This logic model provides a visual representation of the program that will be implemented. Thank you for listening to my presentation about refugees and menstrual health.